Welcome to this live webinar, Cardiac Surgical Arrest, an International Conversation. My name is Jill Lay, Clinical Professor of Nursing at UCSF and founder of Essentials of Cardiac Surgical Resuscitation, an online educational resource on this topic. I will be moderating this 1-hour session today, posing your burning questions to our panel of experts. I'm joined by advanced nurse providers Tara Bartley from SCTS, Christina Ruiz-Segria from EACS, and John Whitlock from the STS, as well as Surgeon Joel Dunning, the king of cows, who developed the first protocol specific to cardiac surgical resuscitation in 2009. While we're waiting for your questions, please feel free to send them in and we'll post them to the panel. I'm going to go ahead and kick things off by asking Tara our first question of this session. Tara, can you please tell us about your most memorable open chest situation and what you learned from it that you can share with others, which means learning new expletives doesn't count?
Oh my goodness, Jill, what a great question. There are a number that have gone less than how we would prefer them to have done over the years prior to CALS, and then the learning curve that comes with CALS and the ensuring that the whole team is on board. I can think of a post-op patient on a ward in a side room. So automatically, you're probably not going to have the space and the environment conducive to opening a chest with lots of people in there. And it was late at night. So again, you probably haven't got the personnel you want. And I was surrounded by a lot of people who probably weren't familiar with CALS at that time. So thinking back, apart from the lack of space, I had a highly esteemed, but at the time, quite junior registrar who arrived, and between the two of us, we opened the chest. And I kind of remember that the person to my left was one of our support workers. So in the UK, that's someone who's not a registered nurse or allied health professional. And she really resonates with me. She was amazing. I asked her to count swabs. I asked her to keep time. And I asked her just to sort of stand near me and sort of, be my number two, so to speak. So I think having clear communication was really helpful. The next thing that happened was, I think this may have been the individual resident doctor's first open chest, or certainly in those situations. And I looked up as we embarked on the procedure, and as is the way, it doesn't matter how senior you are, how experienced you are, you've got fear in your eyes. So the next thing I remember doing was just talking really quietly. So set the scene with everybody doing things, but then just leaning slightly in and looked at him, and I just said, "We've got this. Come on, we'll do it together. Let's go through it." We proceeded, and I remember us working so efficiently together, getting into and being in the chest and looking for the bleeding point and pressure, keeping, counter swabs and all the sort of the theatre things that you would expect to do, as well as the CALS, so the safety side. And then just ensuring that, number 6 role person had called the team and that everybody was coming. And there is that bit, isn't there, where you just think, I'd like other people in the room, So I suppose the things to really pull out are the communication, the tone of voice, how reassuring you can be, and being reassuring to others has a positive impact on you and makes you calmer, I think. And then obviously being pre-planning. So the co-location of the critical care and the theatres was 6 floors away. So, we had not got a CALS principle to take straight back. We were opening on the chest, so we had all the equipment that we needed. But it's having had those conversations and then having personnel around you who you can either know what they're doing, or you can instruct in a gentle way that means that they come on board and don't run in the opposite direction, I suppose. So, and then actually even more funny was, because it was so late, halfway through, someone came to the door and said, Tara, your husband's on the phone. He wants to know what time you're going to get home. So I said, give him a message and tell him I'll ring you back in a bit, please. So anyway, there you go.
Well, I definitely heard some very important points there about planning in advance, about open communication, and about optimizing the skills of everyone in the room, regardless of what their training may be. And I think you do that by being welcoming and reassuring, as it sounds like you were. I'm looking at some audience questions. I'd like to go ahead and take this one. If a patient arrests with VFib and you think it was an RONT, what should you do with the pacemaker during the arrest? So, anybody want to jump in there and take that one? What do you do with a pacemaker if it's on and your patient has an RONT? Jill, do you want to answer that one?
Well, hello everybody. Obviously, I'm Joel here in Middlesbrough. We've been in CALS since 2003, and certainly we get all kinds of questions. Some things we haven't put in our guidelines, and actually, probably it was a bit of a miss in our guidelines to not actually address this issue of what do you do for a patient with VF and RONT. Usually the giveaway sign is that that patient was absolutely perfect, you know, totally fine, not bleeding, not on inotropes, you know, pacing dependent, and then suddenly out of the blue they're going to VF. Because usually for VF you should get some herald signs. So suddenly out of the blue they go out to VF. The CALS protocol says dive for your defib, shock them immediately, and if it is an RONT, they should come back to sinus rhythm straight away. So if they come back to sinus rhythm, that's you. You've saved a life. You're a hero. One thing we, haven't probably done in as well as we could in CALS is do your A, B, and C afterwards. Reassess that patient. Check the airway, check the breathing, check the circulation, and obviously in circulation is recheck your pacemaker. So I think in every single arrest situation you should ABC everything, including the pacemaker, including the drains. So hopefully, if you recheck your pacemaker, you'd go, oh my God. Look at that sensitivity. That's not set well, and get that sensitivity down. So I wouldn't do anything when they're arrested. I'd save their life. I'd ABC them, and as part of every arrest, probably you should reset your pacemaker anyway. So that would be my probably update for the guidelines to just go a little bit further after the arrest.
I'm going to come in and share something that really triggered for me. Actually, I came in one day on a Monday morning after the weekend that I hadn't been working. And the guy said to me, oh, the pacemaker doesn't look quite right, Tara. And when I looked, the patient had been through the ITU and discharged to the ward area, and the sensitivity was not working correctly. And I think just thinking back, that whole thing about what mode are you in, and how a D and an O looks very similar as you get years go by or eyesight fails. And I remember finding this patient on a DOO, and those of you that are listening in, that's the sort of the pacemaker setting of doom, as we say, isn't it? It's the one where the pacemaker's not listening to the heart, and so bad things can happen. And I think that whole thing around rechecking a pacemaker needs to be something that people are very comfortable with, because clearly either people hadn't been comfortable with it or that hadn't been done, and the patient had been through a critical care environment and they had been through a ward environment as well. So there, but the grace of God, we managed to change the pacing and patient was sorted. But it reinforces what Joel said, I think.
I think we mentioned in this series before that pacemakers, I think it's taken for granted. But the education that we give to junior doctors, to nurses, it's not good enough. I mean, it's a serious device that has a lot of implications. We can save their life, or we can kill someone, or we can put it in a very bad mode. And I think we haven't had the proper course or the proper education, the tools that we can share with everyone and train better on this tiny device that is in most of the beds in our cardiothoracic unit. So I think I saw years ago a device that people was designing to kind of train at the same time, because that's the other thing. You can't train this in a classroom. We all training in class, but it's really difficult to train people on a pacing box, just showing the pacing. You really need to practice. You really need to put your hands on. So hopefully someone will recreate a tool or device or something AI or something that we can, with the new technologies, that we can educate our professionals. So
Several years ago, I learned that our pacemaker vendor did actually have a training module, and it had to be scheduled ahead of time. They would bring it in for the medical students and the fellows, but they would not bring it in for the nursing students. And so I, had some issues with that. But nonetheless, I think all of us really have seen the importance of pacing boxes and how they can be your savior or they can absolutely be your doom. One of the things I always go through is troubleshooting. I know that's part of our courses. John, could you tell me what your approach is, how you train your staff to approach a temporary pacemaker to quickly troubleshoot for emergencies such as this?
Well, we have a multi-layered approach to training people on pacemakers. It tends to be the one thing that is, I think, most stressful for nurses being oriented to cardiac surgery, ICU in particular, and the step-down unit. But we have a class that we offer, and then we ask the nurses to check thresholds on every shift that they work. That, to me, is the backbone of what makes the expert with the pacemaker, because they're touching it every day. I'm always surprised at the amount of variability we have here in the United States, at least, of how we approach how staff interact with a pacemaker. It's very different from hospital to hospital on whether nurses even touch a pacemaker. Some don't allow them to, but we kind of bake it into their everyday practice to build up that knowledge level.
So you feel like your nurses all get that education and feel very comfortable troubleshooting those devices?
By the time they're off orientation, they feel at least comfortable enough to troubleshoot.
That's great. Christina, could you talk to us about what you teach and how you might approach training someone?
the pacing is basic, mainly related to the nurses on intensive care, because they high dependency, I will say yes, but probably more the senior grades rather than the junior ones, which probably I think is wrong, something that we should change. And the approach is sometimes in intensive care, the SCCP, which is the advanced practice nurse on duty. Probably with the junior ones, they go through a process of education while the patient is on the pacing. And I still think that we should have a more standard way of educating pacing boxes and the use of them and the dangers of them. But I haven't come across yet to an educational standardized process for pacing. I think it's very hit and miss by the hospital or by the team that you are working with. So
I really agree. I think, years ago, obviously I've been doing this for 100 years. I'm very old. And we used to do the thresholds ourselves in the ICU. And now, our nurses don't. The advanced practice providers do. So I think with the different levels, we just need to be sure that someone is doing these things. And what our nurses do, and this is what I teach them in all of our classes, is that they do an assessment from either starting at the wires to the cable to the box, or the other way back, just to make sure all of your connections are tight and appropriate and your settings are good before you start your shift, so that before anything bad happens that you've at least begun with a reasonable setting and stable device. Christina, would you like to tell us about your most memorable open chest event and what happened and what you learned from it? Certainly the gentleman next to you wouldn't have been there, because I know his patients never have open chests, but
Can't be one of mine.
No, I was thinking, because I was listening to Tara and most of the things that she said came to me. And I want to say that I don't have a memorable case to share with all of you, because I'm afraid over the last 20 years that I've been working here, I've been in so many reopenings. Not because we do really bad, it's just because I used to be a scrub nurse, so I was very close to the reopening settings, so they call you. I will highlight my journey from being a scrub nurse on call when you are called for a reopening, you have to run. From now being into Carl's teaching, Carl's knowing Tara, knowing you, Joel, and then now as an advanced practice, it's totally different. So from someone who didn't know what was going on and lost completely in the reopening, from someone who can now see the roles of each one, help someone if need be, educated. If I think someone was lacking some understanding, I can take them out later. So understanding the rest more than anything. So for me, I would say it's a journey from lost completely to knowing now what's going on.
That's great. I mean, I didn't realize you had those OR skills, but that has to be absolutely, amazingly helpful to what you've been doing. I have another question from the audience that I wanted to pose. Why don't we give Protamine in an arrest if we think the cause of an arrest is bleeding? Shouldn't we do something to correct the coagulopathy? Who wants to address that? Is there anybody that does give Protamine routinely? We used to do that for our bleeds. We used to always give a dose of Protamine. And, again, what is Protamine doing? It's correcting heparin. But anyone want to address that?
Isn't it that age-old question? Is it what we call sort of, iatrogenic or not? I think if you're going to look at a bleeding patient, you need to work out whether it's a clotting issue or not. And in an emergency, you haven't particularly got time for that, and it's very unlikely to be a clotting issue. And in a slow bleed, then you can look at the preoperative state of the patient, you can look at what's going on, you can look at what was found in theatres, and you can give as much Protamine as you like. If there's a bleeding point, then you're going to have to go in and close. And I think that's where those of us that are by the bedside really struggle, when you anecdotally got a feeling as you hold the tube up and it pumps up that this is not a clotting coagulopathy problem, and having to portray that information and get that heard and get teams in. We were discussing this morning actually about a patient that we were handing over, and a few days ago it was very clear that actually they weren't going in the right direction, and it was post wire removal, and there was a slow but not slow enough tamponade, and there was a discussion whether they would come in and open at this 4:30 in the morning and wait or whatever. Fortunately, they decided to have action stations and move things forward because there was a bleeding point in there. So.
Well, of all the algorithms, I find the bleeding one to be the most variable, quite frankly. I think, every hospital sort of has their own recipe for how they approach bleeding, and it may even differ by surgeon. So, Joel, is there any thought to trying to systematize this a bit more? I mean, clearly there are times when you really suspect a coagulopathy. This is a patient who had liver disease or anticoagulants on board before they went to theater or something like that. But is there, sort of a more standardized approach that you think could be brought to this problem?
Yes, absolutely. We may get on to the fact that I have 9 Cal's regrets about setting up the guidelines. So I can tell you 9 things that I would change. One of the things that we've already addressed is that I regret that we didn't talk a bit more about ABC after the arrest. We just stand back, we saved a life, we all walk off. But actually ABCing them and really going through everything systematically is what we actually all do. But we didn't put it in the guidelines. So Protamine is a very good example in fixing the anticoagulation. If somebody arrests with massive bleeding. We need to fix the arrest, get the heart started, get blood to their brain. But yes, of course, after that, we want to fix the coagulopathy. It's just it's not in the guideline. We kind of thought about it. We thought it was too clunky on the poster and not relevant for that first 5 minutes, because the arrest is 5 minutes. But absolutely, after that, get them stable, ABC, team leader, then go through. So how's the airway? How are they going into pulmonary failure? Do we need to suck out the ET tube? Check the pacemaker, check the drains, get a blood gas. We don't talk about that, and then correct the clotting. Have you got a TEG? Have you got a Rotem? And let's whiz along. Another thing I get asked a lot is, wait a sec, I've just come from trauma, and I've just come from resus rooms. We call an emergency blood pack instantly, which has got 1:1:1 blood platelets and FFP. Why don't in CALS do you not demand 1:1:1 CAS pack of blood immediately? And actually, we should be. So actually, these are things that I think if you become senior or you're a trainer, or we want to extend the remit of CALS, we should start trying to go for the next 5 minutes and the next 5 minutes as well.
Thank you. I think you raised a lot of really interesting points there. In terms of the bleeding protocol, when we talked about this during our session, I think all of us acknowledged that we have some type of massive transfusion protocol that we can activate. And that, I think, has become endemic in our organization. So we rely on that process when we've identified a patient who's bleeding, regardless of if it's a coagulopathy or not. But I think, more nuanced is, there are patients that, you're not sure. And because it's so variable, what resources do you have? Do you have a TEG? Do you have a Rotem? Are you going to wait an hour for a Protamine or something like that? It just leaves us to, I think, have a lot more variability in these protocols than, say, shock 3 times, something like that.
I think why, Jill, it becomes really important to have a CALS team, like a teaching educational in your unit, because then they can realize those tiny things that you need to add into the CALS guidelines. So if you think you need to update other things and they are not covered in the guidelines, then it's when it becomes really, really helpful.
And I think we've all emphasized how much, you have to use judgment and clinical acumen as you approach these patients. And so hearing the history, my plea to the nurse that's taking care of the patient is don't run screaming from the building. Stay here. We need to know, is this a patient who had their pacemaker wires pulled 2 hours ago? Is this a patient whose potassium level was low? Is this a patient who, had a lot of bleeding in the operating room? These are things that are very helpful to the team, and they may not know that when they're the first responders. So those types of things are super helpful. But again, I think the bleeding algorithm is the one where I see the most variability, and certainly in our own institution as well as around the country. John Whitlock, do you want to tell us about your most memorable open chest situation and what you've learned from it?
Well, actually, mine's more of a story because I wasn't present at the actual opening of a chest. About 10 years ago, we had a patient arrest on the step-down unit, and we eventually performed resternotomy on a patient that was about 10 days post-op. Unfortunately, the patient had a poor outcome because she had a noxic brain injury. And at that time, we had just started training the nurses in the ICU, the CALS protocol. The step-down unit nurses were traumatized by the experience and angry at me as the educator, frankly, because we had taken the time to train the ICU nurses, but offered nothing to the step-down nurses. So they felt in many ways powerless and unprepared. Segue 3 years later, I was coming into work in the meantime. So shortly after that experience, we did start training the step-down nurses in a modified CALS protocol, mostly placing them in a supportive role for the ICU team members that would show up. We also mirrored the carts that we kept in the ICU in the step-down unit so that the equipment was exactly the same in both units. Again, segue a few years later, I was coming into work at just about 7 in the morning. As I was leaving the parking garage, I work at a teaching hospital in Boston. I passed one of the nurses that worked on that step down unit and said, "Hey, how are you?" He said, "Oh my God, I'm great. I'm great." And I said, "What happened?" And he said, "Well, we had an open chest arrest last night." I said, "Oh my God, the patient's okay?" He said, "Actually, the patient didn't survive, but I knew what I was doing, John." And that was one of the most satisfying experiences I've had around this whole CALS journey, I have to say.
That's a great story. I mean, again, I've been doing this for a very long time, and I distinctly remember back in the 90s working with my surgeon to have a protocol. This was before Joel developed his, and there were too many steps. It was, call this person, get this, it wasn't streamlined enough. And so I think this was, the big aha moment for me was reading this paper that Joel put out and seeing how absolutely effective this could be. And then seeing it in real life, it's just been an absolute deal changer. So I think you raise a really important question. These events happen not just in our intensive care unit, but in step down areas as well. And so I get a lot of questions about that. And my training program is being used throughout the country. And many people are training their step down units in some way, shape, or form. Joel will acknowledge what the guideline says about step down areas. Joel, what are we supposed to remember for step down?
Regrets, I've had a few. We're going to get through all my regrets, and one of them is
Don't have that much time, dear.
Yeah, well, maybe our next webinar is how do we change CALS and how do we change the guidelines and how do we improve things? Because I think that would be a really interesting
Ooh, there's my
talk.
first podcast.
I have 9 things I would change. And one of them is we had to be very, very strict about where we felt it was applicable, because we were really freaked about the idea that in a step down unit, a thoracic patient and a pediatric patient and a medical outlier patient could be next to a cardiac patient and somebody could try and rip their chest open. So we were pretty conservative about it. And we said that the CALS guideline through the STS and EACTS both said ICU only. But we did say in that you can choose to then extrapolate these guidelines if you wish to step down units of all types. And people have taken that to mean that, if you're in a pure cardiac ward on the floor, you could choose to train CALS. Or you could choose that actually that's not frequent enough. Let's bring an expert team. We've got a high dependency unit very near to our intensive care. So we choose to run CALS, but we bring the team from the intensive care. So it's not mandated in our protocol, but we really ask every unit to look at their own situation and to look at their step down units, whether they think they would like them to actually actively open chest, or whether they should call the intensive care, or whether they should just do standard guidelines and call the experts.
I mean, the key thing is that you've thought about it before. And what the guideline does say is we absolutely should still follow the recommendations for shocking in step down areas, as well as the restricted use of epinephrine. And so with those things as a starting point, then I think you really look at your data and you see what you need. We looked at our data and saw that in 10 years, we'd had 1 open chest in our ward, and it was not a salvageable situation. So what we trained our nurses to do was to shock 3 times and to troubleshoot pacemakers. And our step down unit continues to have those skills and have saved over a dozen patients before the code team got there. Should they need to open a chest, the ICU team would come and be the ones to actually assist. I agree. I don't think it makes sense, at least in our hospital, for all of our step down nurses to learn this. But I've had other facilities that felt that that was helpful for them. So I think there's a lot of different ways that you can implement this.
I think, Jill, the other thing that we've talked about on the series that I'd probably like to raise again is, at the beginning of a shift, to allocate roles. So if the unit that I work in, if you go on in the morning, there is a whiteboard behind the main station where everybody collects, and it book's got everybody's name on in the 6 key roles and any additional roles that they want. That way, you're not making decisions under duress, you know, in a time concerning way. You made the decision beforehand, and you've already set it up to work seamlessly, whether that's opening the chest on the critical care unit or going to the, you know, the ward area to support and to have an overview there as well.
Thank you. I've got another question that I wanted to address, and it's basically about the use of paddles. We've all gotten used to using the hands-free pads, but in this particular question, it says in very obese patients, I've heard pressing hard with paddles and shocking is more effective than pads. Should we be keeping paddles on our unit for high BMI patients? Anybody want to take this question? I mean, first of all, I wasn't aware that pressing harder was any more effective with an obese patient than pads were. I haven't seen any data on that. The only thing I have seen, which is something we talked about in our session and all of us poo-pooed, was the double sequential external defibrillation, where you put 2 sets of defibrillator pads on and shock essentially simultaneously. But we actually have gotten rid of all of our paddles. I don't think we have those on any of our defibrillators. Anybody else still keep paddles around? No.
I would say when we did our literature review for our guidelines called REACT in the cath lab, an electrophysiologist said that he has found that you can more effectively defibrillate, and he's an electrophysiologist, if you press on the pads, and he tends to use paddles to press on the pads. And then he showed me 2 papers that in obese patients, this actually could more effectively shock a patient. I think it's not part of our guidelines. I think it would be crazy and a backward step to move to paddles, and I think we should stick to the CALS protocols of 3 shocks, and if they fail, open the chest and shock from the inside. The heart is not fat enough to not take a shock on the inside, even if it is on the outside. It was a quirky paper. I have had that question, and we just say no to paddles. Don't do it.
Well, that was actually funny, because that was the same answer we came up with this double sequential. It was like, what are you mucking around with all that stuff? If you fail 3 shocks, you open. That's what we're going to do. We're not going to do any of those other fancy things. Joel, would you like an opportunity to tell us about your most memorable open chest event?
Oh, well, thank you so much. Well, of course, I think we must mention the first open arrest using the CALS protocol that was on the 30th of September 2007 by an amazing nurse called Mario Hughes, who Christina may remember, who's just an incredible guy. He was super enthusiastic. He came to our first courses when we did them in Stoke, and he really got it and understood it. And he was an incredible, ahead of his time, just senior nurse on the ward. There weren't nurse practitioners in our ward then, but he was very happy to do what he thought was right. And on the 15th of September 2007, it was a Saturday, we just did an AVR, and I went back with Simon Kendall. I was just a trainee to go and do the second case. We're on bypass, and without warning, our first case arrested. He didn't wait for us. He knew it was a tamponade. He opened the chest because we've been practicing it. He opened the chest in 3 minutes of 27 because I knew someone was timing. That patient made complete recovery and went home neurologically perfect 15 days post-surgery. I'd want to mention in our unit that we've been doing training so consistently, and Christina's actually our main trainer, so huge congratulations to her. We've had some amazing successes with our critical care non-doctor practitioners. And I know Katie Gofton, who's one of our senior CCPs and used to teach in our course, has reopened 12 chests without surgeons herself. But the most amazing thing is she hasn't had a death yet, which I think is incredible. The one other sort of arrest maybe I should mention is that we actually had a step-down unit arrest. It was on our ward actually, and I came along. Everybody came along. The whole world comes to all these things. But again, we were training really well, so we'd already got a team gown, gloved and draped and ready. But the consultant surgeon, who was that patient's surgeon, was there at the arrest. It was a 55-year-old guy after grafts with cardiomyopathy with a big dilated heart, and he'd had to shock the patient quite a lot in the operating room. And we did 3 shocks, and then the team was, should we reopen? And he said no. and everyone stared at him, and because everybody else in the room wanted to open, and he was like, no, I think we should shock again. And so we all stared at each other, and we were like, well, he's the consultant, so we shocked him 3 more times, and then we're like, what do you want to do now? And eventually he could get the vibes in the room. They were literally scrubbed with everything ready. And so he's like, okay, go on then. And the team opened the chest, put the retractor in, defibbed after decompressing the heart, which was very big, came back in one shock. So I thought that was a really lovely example of how our trained team got around, sort of made sure the protocol happened really nicely, and even persuaded one of our consultant colleagues that we were doing the right thing.
Well, that's a great story. And that's one of the questions that I have for the nursing providers here. What do you do if you're there and, the surgeon doesn't want to reopen? What strategies can you use? And we talk about some of these with our human factors. Anybody want to jump in there with suggestions about, how to approach the reluctant provider other than just put a scalpel in their hand? Hint,
So-
hint.
I'm happy to kick off this conversation, Jill, because I think, we can be quite critical of our surgical colleagues. And I think we in the UK have moved beyond the surgeon-specific data that was out there. But actually, you don't know what has shaped them into the practitioner that they are. And you don't know whether they've had some dreadful experiences that makes them, more risk averse and anxious. And at the end of the day, they're all humans. So just because somebody has a title doesn't mean it makes you better able to cope with a situation from an emotional as well as a knowledgeable sense. So I think with that in mind, the gentle approach and the mutual respect is key, and an understanding of their rationale. They may well have had like your colleague Joel, they have had sight of the surgical bed. They have knowledge that you haven't had from not being in theatres. And so they may have a very good rationale for what they're doing. So if you allow them the opportunity to explain that rationale, preferably quite quickly, because we have a time, limited. We want to perfuse the head. We want the patient to do well. We want them to go home and give us chocolates before they go home and any other presents that they are choosing to share. So I think, you must ask a rationale. And if they can't come up with a rationale, you can talk about evidence base, you can talk about alternative practices, and you can escalate according to the sort of any of the human factors, sort of challenges that are polite, that say, had you thought about this? Do you think we should do this? I really think we should do this. But the way in which you do it, we all know, don't we, in human life, that if we go to somebody and we say, you need to do it like that, then actually, whether it's, a child at home or someone in a social environment or someone in a professional environment, they're more likely to stick their heels in and go, no. And, you need to preserve their dignity. So I would suggest that using all of those skills is important. And then actually, sometimes if it's a very, a person that threatens that person's whatever, then perhaps somebody else needs to suggest it in a different way and quietly or more forcefully or whatever. I don't know what others think. Be interested to see.
I think it's different from hospital to hospital. It's different from country to country. There is some countries where the surgeon is God. Sorry, John.
Not here.
Present company excluded.
And you have to do what the surgeon said regardless. And I think in those situations it's really difficult. But I want to believe that we're moving away from this type of surgery. We can see this even in places when you see now discussions when everyone is including the nursing team, the anesthetic team. So we're moving into a more teamwork participation. And I think we can see that on the cardiac arrest. And I definitely see that from my journey over these years. And UK is very advanced compared to other places. But when you teach abroad as well, you can see those things, that they are moving more into a truce-wise. And when there's a cardiac arrest, it's not just what the surgeon says, it's what the anesthetist says, what the surgeon says, what the nurse was there. So I think it's a bit more a team decision, but yes, in some places they probably more, there will be still conversations on a surgeon will deny to do something or go or follow that guidelines, and it's going to be pretty difficult.
I think part of the reluctance that I've seen in the past has been that, frankly, the surgeons didn't think that they had, good assistants and a team that was there in the ICU that could really help them. And so they felt more comfortable taking the patient to the ICU. I mean, out of the ICU into the operating room. Now they know the data says you don't have 9 minutes to get in an elevator and go somewhere else. And our staff knows exactly what to do. And so I think we basically, it's like training horses. Put the carrots over here. Make it, we've put enough carrots out there that we now are moving in that direction, I think, largely. So I don't see this happening very much at all anymore, but I like to address the question for everyone. Thank you very much. Now, I'm going to ask this question and then I'll answer it myself because I have lots of thoughts about this. What research would you like to see conducted in this field? I just see so many unanswered questions about, what we could be doing better. And I mentioned on our webinar that I think hand position for compressions, particularly if a patient has an open chest, that's something that we really need to study in order to identify exactly how to get the best perfusion during these unusual situations. Could anybody else jump in there and tell me what research you'd like to see?
Outcomes.
I love it.
Hmm.
John, thank you for being one of the providers who has published their outcomes, and they're outstanding. What else? Expand on that just a bit.
Well, outcomes are essentially the foundation for everything we do in medicine, right? And so these individual hospitals research into the success or failure of CAL's protocols is not helpful because our numbers are so low. So I think that we really, really need to make a concerted effort to get as much data from as many hospitals collectively as possible to look at the outcomes before CAL's protocols were instituted and after to see if we're actually making a difference on mortality rates.
Thank you. Absolutely agree with you completely. Tara, what research would you like to see in this field?
I agree with you. There's quite a few things really, isn't there? I mean, the essence of what we want to do is quite difficult to have a controlled study, clearly. I think possibly the things that make CALS work well. So something along the lines, and this is something we have looked at in the past with other courses that we've run across the UK through the SCTS, Society of Cardiothoracic Surgery, is looking at confidence and knowledge base prior to having teaching, and then looking at it post-teaching. For our colleagues, and then perhaps revisiting that sort of 3 and 6 months down the line to see what the retention of knowledge and confidence is, and using that to inform how often we should be doing the teaching. And I know there are various units around the country that, if you come on a Monday morning and there's been less operating, that you can actually just set up a empty bed space and set off a cardiac arrest as a real-time practice prior to patients coming back out of theatres, providing the current patients aren't distressed by it in the unit. So you can go from the sort of the formal teaching setting into the informal, sort of more hands-on, as Christina said earlier, that hands-on side of things. So I think looking at how often we do this and how often we should be doing it. And also, John gave us that anecdote around meeting somebody who the process had not been successful, the patient, but actually they themselves felt that they did the best job that they could, and not traumatizing our colleagues and giving them the wherewithal to be able to perform as well as they can is crucial, really, I think.
Absolutely. Christina, I understand you're doing some fun things with virtual reality training these days. Could you expand on that just a little bit?
Not doing these days. We did it in the past. We brought an amazing team that works with lots of new technologies, VR, AI. They develop lots of things, and we work together. One of the things that we should look into is revalidation, probably, is it? That's what we're talking about. Do we need to revalidate this course every 1 year or every 2 years? At the moment here, at least in our hospital resource, they force, and I'll say force because nursing staff, they really hate to go into the resource training, because they have to do a bit of role playing, and they don't like that in front of the classroom. And that's why we came as well with the VR sets, because they can train themselves not in front of peers, not in front of other people that you work with. And if they make a mistake, no one will know because you are with your VR set and no one will see. So it's kind of what we did. People really love to come to CALS, but they still don't like this role playing bit, because nurses will never train. It is not part of our training, this role playing. I think it's getting more into, but we're still not used to. With medical stuff, they do all the time from day one, from medical school. So when we did with VR, it was looking at this, looking at times, and basically getting confident. So, but having your own space with the virtual reality, and getting hands-on and doing your things. If you make a mistake, the machine will tell you. That brought the confidence of people, and they felt like they trained a bit better on their own
I
time.
think that's a great idea. I mean, I remember seeing the headset at the EX meeting, and we're all looking for ways to make sure that people get this education timely. Jill Engel from Duke did a study years ago and showed that within 6 months, there's a pretty substantial drop off. We have an audience question from a good colleague, Jeff Hinman, has been doing their training, and they now have got their entire team and step down area trained. Good work, Jeff. Your question is, how often are you conducting mock drills, practice drills in your ICU? So again, I think you're getting at the question that we're all trained to, answer. How often do we need to do this to make sure that people still are comfortable with the material? John Whitlock, how often do you do your training or mock drills or anything? Tell us a little bit about your model.
Well, thanks for asking the question, Jeff, because I'm pretty proud of the model that we've adopted at my hospital. We have a monthly skills day that nurses go through that involves 5 45-minute stations. One of those stations is a mock open chest arrest in the unit. So every month in the morning and in the afternoon, we have mock open chests in the unit. That's the important thing, because that allows me to involve the intensivist surgeons that are available, training advanced practice providers, pharmacists, the secretaries on the unit so they know who to call, all of the ancillary folks that are involved in an open chest arrest get a chance to ask questions and talk through it. So that has really been what's taken us over the top and across the finish line.
Wow. Well, so monthly drills, no wonder you have an 87% success rate. That's pretty outstanding. Christina, how often are you doing your training these days?
I'm not sure how many times. I know staff, they do counts every year, the senior people, and every 2 years, the rest. And then they run mini counts ad hoc, so when they can, but it's not like as a standard as John is saying. But again, that's what we was just saying. We need to confirm when we need to do those revalidations, and if do like a mini counts every week will help you, or every 6 months, or and as you said, Jill, we know the knowledge and the skills, they drop down after 6 weeks and then even further after 6 months. And so it's data on other projects on knowledge retention. So we know that, but we haven't done anything on CALS specific. So it will be interesting if anyone got time to do some research.
And Tara, I know, you were in the UK where this all started. So you set the model of training and centers of excellence and that sort of thing. How often are you training now?
It's interesting, isn't it? So we used to run an advanced practice and a basic core skills course, and we used to do CALS on that. In terms of individual units, it's very much determined by that individual unit, who leads it, the resources. So some are monthly, some are 3-monthly, etc. But what I would say is that on those courses, you probably only have a handful of the staff, albeit John brings all the other, professional people onto it that should be multi-professional, but you can't get everybody into one day. So actually you could find with, attrition of staff that some people don't get it nearly as often as they should do. So I'm very much in agreement back with Christina. How often how often should you do it? And again, individuals remember things at different ways as well and different times. So that needs to be taken into account. I mean, certainly we do need to do it in a more relaxed way so that people are able to take the information in and process it rather than being scared and anxious about not performing correctly. So I think in terms of it is a great question, and I'd be interested to see what other people think. And I think it depends on throughput, depends how often you have an open chest, number of different variables. It would be a challenging piece of research, I think.
I would just say one more thing here, Jill. Not everybody has the same resources, and that it drives a lot of how different organizations approach their training. Not everybody can afford to pay somebody for an 8-hour training. Not everybody has an empty bed to do the practice. I'm sure it's the same in the UK, but here in the States, beds don't stay empty for very long. It's driven a lot by the resources that you have available. So you kind of patch together the best you can.
Yeah, I think,
And I think,
sorry, Jill, just adding to John, when we did the VR in EADS a few years ago, most of the surgeons, the European surgeons, they came to us about how you can get this VR, because my staff, they don't have the time to revalidate. They can do the course once, but they can't do it again because we don't have enough, because the ratios for nursing in other countries, they are very, very low compared to UK, or I'm not sure about USA, but and they thought VR could be used as like a 10-minute play game that they can refresh everything. And even I think Adrian workout as well, or he was talking about doing some games on the phone, because we all have time on the break to do a bit of game on the phone. So maybe we just need to think about technologies and how to use those new technologies in helping with these resources or non-resources, which is the time we can buy.
We need an app for that. I want to mention one thing that I learned from John, and I found it absolutely invaluable. And that was, I think you told me that you were doing in your sort of annual competency or code training for everyone, you included one open chest, even for the nurses that don't normally work on the heart team. And I just thought that was brilliant, because the nurses that don't necessarily care for the heart team or for those patients may still be in the unit and want to help. And like that nurse in the step down unit, they're going to wind up feeling demoralized if they have no clue as to how to offer help at all. So even those nurses that aren't taking care of these open heart patients yet, I think just to have been exposed at some kind of a drill and see how different it is, so that they at least have some some exposure to it has been absolutely vital. And we started doing that, and I can't tell you how invaluable that was, because at any given time, we've got, a good share of nurses that aren't yet trained for hearts. So we have to consider that everybody in the unit wants to make their optimal contribution. We are quickly running out of time. So I want to just basically take this last opportunity to ask each and every one of you, give me the one pearl that you want to make sure that your students hear before they leave your class. And I'm going to start with you, Joel. With every class, what is it that you think is the most important thing that any provider in the room needs to hear?
Well, I'll give you another regret that we don't teach the importance of internal massage enough. A lot of people that come on our courses think the only reason you open a chest is to exclude a tamponade. So they get very disappointed if they don't see anything. But actually we should up the importance of open the chest, do massage. That's an amazing way to do CPR. It's way better than external massage to get rid of that disappointment in real life when they didn't find a tamponade. So that would be the thing I would teach more often.
Perfect. Christina, what is it that you really like to emphasize for your trainees?
I would like to emphasize that this is a teamwork. It's not an individual person. And when you're doing an arrest, there is lots of people around and you need to talk to each other. So for me, it's teamwork and communication, something that we need to learn. And we don't do very well sometimes on the communication part. So for me, that's probably the bit.
But I think we're getting better since we've been taking this course. Absolutely. Teamwork. John, how about you?
I would say stay calm and build off Christina's point to clearly communicate. If those things are in place, kind of everything else works out.
I love it. And Tara, what is the pearl that you make sure every one of your students hears?
I think early recognition of the deteriorating patient. Is it a pre-pump? Is it a post-pump? Is it a pump problem? And that whole system that we teach on the 5-point plan on recognizing a problem before it becomes a need to open a chest and getting your voice heard so that you avoid opening the chest. And that again is around communication. And again, while we don't necessarily teach the open chest skills to every member of staff, we certainly should be teaching the deteriorating patient to every member of staff. And those scenarios that we have within the CALS course are excellent at doing that for the nurse or the individual by the bedside.
Absolutely. For me, I think it's really just the fact that we plan ahead and practice, and that people have in their head, they know what roles are expected. There isn't a big guessing game. They immediately know, I'm going to go to pacing, I'm going to do, medications. And so I think having that clarity with this wonderful protocol and then the opportunity to plan for it and practice it has just been a complete deal changer in terms of how our patients respond, and the results are showing it. So again, to emphasize what John Whitlock said earlier, we're seeing success rates of 65 to 87% being reported in the literature, whereas the general population remains around, below 30%. So our results are outstanding. Our thanks to Joel for his work on this. With that, I'd like to close on behalf of our CTSNet panel. Thank you so much, all of my experts, for joining us, and for our audience as well. We hope you found this entire series to be interesting and insightful for your practice. My highest regards to the panel for giving up their Wednesday mornings all summer long, and for Joel to join us and share his expertise today. If you haven't seen them yet, all 5 videos are available at ctsnet.org. Many thanks for your participation today. Cheers on behalf of all of us. Thanks so much.
Thank you.
Well done, Jill. Great job.
Yes. Excellent panel as well.